Welcome to the second part of our two-part podcast on individualizing management of uncontrolled asthma, new strategies. Our faculty are Dr. Larry Herman of the University of Lynchburg and Dr. Samuel Louie, Professor Emeritus in the Division of Pulmonary and Critical Care Medicine at the University of California, Davis in Davis. This program was recorded live during the PCE Symposia Series in June 2021. At the conclusion of the podcast, please go to pce.is/UA to claim your credit. This episode is certified for 0.50 ANCC contact hours and 0.50 AAPA credits. When we left off, our patient Grace was found to have very poorly controlled asthma based on her symptoms and ACT score. Although her primary care practitioner stepped up her therapy, she experienced an exacerbation on a cold, dry evening with her fireplace in use. She was treated in the ED and is now back with her primary care practitioner. Let's hear from Dr. Herman as he picks up the case.
You asked Grace to demonstrate how she uses her fluticasone salmeterol DPI. Which of the following common errors in inhaler technique are you most likely to see? Is it 1, incorrect preparation, 2, not exhaling fully before inhaling the medication? Is it 3, failing to inhale with 1 brisk, accelerated deep breath? Is it 4, lack of post-inhalation breath hold? Or is it 5, you're uncertain what the most common error is? So please make your choice now. 49% of you got it right by saying not exhaling fully before inhaling. So I'm going to flip it back to you, Sam, to talk about common errors.
Yeah, thank you, Larry. This is a graph from a study that was published in Chest in 2016. And it basically looked at over 54,000 patients that were studied in 144 articles over a 40-year period from 1975 to 2014. And what they found was that 69% of the patients did not demonstrate correct inhaler technique. The first 20 years were no better than the last 20 years. And I suspect the next 20 years will be just the same unless you and I make an effort to assess the patient's inhaler technique. And what I do in my practice, I ask patients a very simple question. How quickly does albuterol work for you when you need it to work? Does it take 1 minute, 2 minutes, 5 minutes, or 10 minutes to work? The correct answer is 1, maybe 2 minutes tops. 40% of my patients in my own practice say it takes more than 5 minutes to work. So we have an opportunity to help patients. And the way to promote proper inhaler technique is demonstrated on these slides. You want to choose what you think is the best delivery device to check their inhaler technique at every single visit. And again, to correct them and basically to confirm. And this is a repetitive process, but it's about the patient's safety, more important than anything else. So take steps to ensure that your patient understands the proper inhaler technique and they can actually administer their medication correctly. So we return now to Grace. We have a checklist. Larry, you want to go over this case with our colleagues?
Sure. Thanks. So let's make sure we're investigating risk factors that could contribute to poor control before you step up her treatment. Has she been using her inhaler as directed? And be non-judgmental. Otherwise, you're going to get a dishonest answer. Can she demonstrate correct inhaler technique in front of you? I ask people to brown bag it. Bring all your medications with you in a brown bag at every visit. Has she had problems with allergies? Anything new in the house? New pets? A fireplace, something. In this case, no, she's never had allergies. Has she been exposed to any new irritants, such as the fireplace or cold air, that may have triggered her recent exacerbation? So you adjust from GINA step 4 to step 5. You increase the dose of her fluticasone salmeterol combination, the 1 inhalation of the 500/50 twice daily, which is the high dose ICS, and salmeterol is the fixed dose in that combination. And then 3 weeks later, because you've now assessed, you've adjusted treatment, you now need to review her response. 3 weeks later, her ACT score is 13 out of 25. She was 9. Symptoms are still not controlled. So then you would, once again, you've reassessed, adjust the treatment. So you add LAMA tiotropium. As we do that, 4 weeks later, she has another hospitalization due to an exacerbation. She had a respiratory infection, but didn't call you per her asthma action plan. She had coughing, wheezing, chest tightness, all of which worsened. She used the albuterol inhaler, but without significant relief. Her self-monitored peak flow was 200. She went to the ED, was admitted due to her continued wheezing, insomnia from shortness of breath, and physical exhaustion despite albuterol treatments. She was given a prednisone burst in the hospital, discharged 3 days later with a 10-day taper and instructions to see her PCP. So with that, I'll flip that back to you, Sam, please.
Boy, our patient's not doing very well, is she? And now she has to endure the risk associated with oral corticosteroid use. Our colleagues are aware of the long-term risk of taking oral corticosteroids. They can get Cushing's syndrome, obesity, diabetes, get osteoporosis. But I don't think our colleagues are aware that there are short-term risks in using oral corticosteroids. You can basically increase your risk for infection, sepsis, 5-fold. You can break your bone. There's nearly a 2-fold increased risk. And even venous thromboembolism is increased 3-fold in a study in the United States. As a consequence, I think it's really a priority now to, again, we want to put our patient safety first, but are we missing something, Larry? I mean, are we doing something to hurt the patient? Are we not doing enough for the patient? This is why I think this is a good point to return to the GINA control-based asthma management cycle. Clearly, the patient is not responding when we review the response. And this may be the opportunity to really call somebody who can help, because now that she's discharged from the hospital, she needs help. And nothing better than to call a colleague who has a little more experience, a little more expertise in asthma. So when should you consider a referral? Well, when you're having difficulty making the diagnosis of asthma, if there are any risk factors for asthma-related death, and Grace certainly has one, being hospitalized. She has persistent uncontrolled asthma. That's Grace. Frequent exacerbations, that plenty. She doesn't have occupational asthma. She may be at risk for significant drug side effects from oral corticosteroids. She continues. And certainly the last one is really key. She's uncontrolled despite your attempts and my attempt to manage her, to control her with high-dose ICS plus LABA and oral corticosteroids.
Based on a thorough workup, the asthma specialist concludes that Grace has type 2 inflammation in asthma. Which of the following findings would support that conclusion? Is it a blood eosinophil count of 110 cells, or is it a blood EO count of 310, or is it a FeNO of 5 parts per billion, or an FeNO of 15, or you are uncertain? And I suspect there are going to be a fair number of uncertain people, because some of these things are not commonly done in primary care. They can be done, but not commonly done. So go ahead and answer. The correct answer is a blood eosinophil count of 310. 49% of you got that right. So for this one slide, and then I'm going to grab it back again after this one, Sam, talk about what the criteria are, please.
Yes. Larry, the GINA guidelines, as well as the NIH guidelines, has basically stated that type 2 inflammation should be considered if a patient has any of the following while on high-dose inhaled corticosteroids or daily, and I would probably introduce intermittent use of oral corticosteroids. And if you look at this list, eosinophils, 150 or greater, exhaled nitric oxide, 20 parts per billion or greater, a sputum eosinophil, basically 2% or greater, or asthma is clinically allergy-driven. We know from what we've just talked about, Larry, that Grace's eosinophil count in the blood is greater than 150. Larry, do you want to take it from there?
You and the asthma specialist confirm asthma is the diagnosis, so that's a good thing. Adherence and inhaler technique, she has been using it correctly. You further evaluate markers of allergy and inflammation, and she has severe asthma, both allergic and late onset phenotypes with type 2 inflammation, uncontrolled with a high dose ICS. And what you see here is in the middle is Grace's results, and the references are to the right. So her FEV1 FVC is 65%, her FEV1 is 58% of predicted. Her total serum IgE specific antibodies are 85, blood EOs are 220, and Fe nitrous is 55 parts. So she checks every single one of these, I believe, or at least 3 out of the 4 of them. So what might be the next treatment step for Grace? Is it 1, to add prednisone, 2, to begin low-dose macrolide therapy, 3, to maintain high-dose ICS-LABA and tiotropium and add Dupilumab, or is it 4, to taper to medium-dose ICS-LABA and a leukotriene receptor drug and discontinue TIO, or you're uncertain? And the correct answer is 3. 52% of you said maintain high-dose ICS-LABA and TIO and then add Dupilumab. And we'll talk about that in a moment. But the next step in Grace's stepwise management now, she has evidence of type 2 inflammation. So what we would do here under the GINA guidelines is consider clinical type 2 phenotype for which specific add-on treatment is available. Add-on biologic options include either an anti-IgE, an anti-interleukin 5-5R, or an anti-interleukin 4R IL-13R, as well as a healthy diet, tune-up or vaccinations, manage your stress, and pulmonary rehab. You are not getting out of the office in 20 minutes. So plan on spending a little time educating her on this. And back to you to explain exactly how the biologics work, Sam.
Thank you, Larry. And again, in the past, we were left with leaving people on high-dose steroids, trying methotrexate, cyclosporin, even gold compounds. But biologics target the underlying disease mechanism in severe asthma. And what you have on the slide going from left to right is an antigen-presenting cell, basically influences a T lymphocyte to differentiate into a type 2 cell, Th2 cell, helper cell. And this causes B cells to, again, make IgE antibodies, causes isotype switching. As you see in the bottom right-hand corner, Omalizumab binds to circulating IgE. And if you look at the very top, you have receptors, IL-4 receptors, which is what Dupilumab binds to. And this interrupts the cytokine pathway. Going to the middle slide, going from the bottom up, you have eosinophil, that's the green cell, and you have benralizumab that binds to the interleukin 5 receptor, and you have basically either mepolizumab or reslizumab that combines circulating IL-5. So biologics may improve asthma control and reduce the need for oral corticosteroids. The randomized clinical studies support the oral corticosteroid effects of benralizumab, Dupilumab, mepolizumab, Omalizumab, and reslizumab. And that's a mouthful, like Larry said. So let's kind of go into a little more detail. Now, the anti-IgE biologic is Omalizumab, is indicated in moderate to severe asthma patients 6 years and older. These patients have to demonstrate the presence of a perennial air allergen hypersensitivity. It's also been approved for the treatment of idiopathic urticaria, chronic idiopathic urticaria, and very recently it's been approved for the maintenance treatment of adults with inadequate controlled nasal polyposis. There is a risk for anaphylaxis, so an EpiPen is necessary, as well as monitor patient after injections. The anti-IL-4 receptor blocker, which also blocks the formation of an IL-13 receptor biologic, is Dupilumab. This is approved not only for the treatment of moderate to severe asthma, but asthma that demonstrates an eosinophilic phenotype or is dependent on oral corticosteroids. So, Larry, I think this really fits Grace's clinical profile very well. It is also indicated for treating patients who are inadequate control if they have nasal polyposis. And again, we found that Grace, in her history, had it in the past. We couldn't see it on direct examination. And of course, Dupilumab has been used for the treatment of eczema. The anti-IL-5 receptor blocker is benralizumab. This is approved for 12 years and older. Again, it binds to the receptor, preventing basically interleukin 5 from causing eosinophils to differentiate and to proliferate. And you can bind the interleukin 5 cytokine with either mepolizumab, which is indicated in patients 6 years and older, or with intravenous reslizumab, which is indicated for 18 years and older and carries an anaphylaxis boxed warning. So, Larry, can you wrap this up for us, please?
Sure. Thank you. Given Grace's blood eosinophilia, high FeNO level, and history of chronic rhinosinusitis with nasal polyps, the asthma specialist recommends the addition of Dupilumab to her current high-dose ICS, LABA, and tiotropium and intranasal steroid regimen. She then reports that her asthma is now well controlled. She's been able to stay in the green zone part of her action plan for the past 2 months. Her ACT score is now 21 out of 25, so above that 19 level. Rhinosinusitis and nasal polyposis has improved, and she will be evaluated every 2 weeks initially with specific instructions to contact you or the asthma specialist if her symptoms worsen. Treatment with a high-dose ICS plus LABA may be decreased in 3 to 6 months if she continues to do well. Tiotropium may not be needed, and Dupilumab should be continued. So I'm going to ask you if you would be kind enough to just briefly go through the PCE action plan.
I think our patient is very lucky to have come to our attention. She basically is an example of what the PCE action plan does. It promotes a better change in the way we practice medicine. It's about patient safety. Consider using an evidence-based stepwise approach such as GINA to guide individualization of your management. Help your patients by writing down what they need to do at home in case their asthma worsens. That is the asthma action plan. Make sure you look at the whole patient, look for comorbidities, and especially medications that can interfere with how your medications prescribed can work. And if patients continue to have persistent symptoms or have exacerbations despite 2 to 3 months of controlled therapy, again, consider treating these common problems. We're stepping up therapy. But if you need to, consult with an asthmatologist, an asthma specialist. Take steps to make sure your patient uses their inhaler properly. And please try to avoid long-term or frequent use of oral corticosteroids. That suggests that we have failed with our treatment, and this patient may need step 5 in the GINA guidelines. They may need referral to a specialist.
So Sam, let's go ahead and move into some of these questions. Do we need 12% or 200, or do we need 12% and 200?
Larry, that's an excellent question. The American Thoracic Society says 12% and 200 ml improvement in FEV1 or FVC. Now, worldwide, if you basically improve by 15% or greater, that's a bronchodilator response.
Okay, thank you for that. And there is no commercially available phenotyping. We're doing this with surrogate markers. Is that a correct way of describing it?
That is absolutely correct, Larry. Again, total IgE, an immunocap, blood eosinophil count, and basically, again, the clinical impression. I mean, there's no single phenotype test for asthma.
Hing is asking a question about an asthmatic patient who also has heart failure, and it used to be called congestive heart failure, but now it's pure heart failure is what it's called, because you have HFpEF, HFrEF, all of these mid types, asking about beta blockers. And the answer is there are beta blockers that are more selective than other beta blockers. Every beta blocker is slightly different, but there are at least a couple that are better choices. What would you recommend?
Well, again, a beta selective beta blocker, we use a fair amount of systolic in our patients. But in my experience, Larry, and I want to ask you for yours as well, I haven't seen what FDA has continually cautioned us to wonder or to look at the effects of a beta blocker in patients receiving beta agonists. Again, if patients are not doing better on a beta agonist and they're on a beta blocker, there may be an interaction, but I've seldom ever encountered that. This is different when you look at drugs like propranolol.
Right. So the Inderols and propanolols, those are not your best choice. And they're not appropriate for treating a patient with CHF regardless. They're not your choice. So, no, I agree completely. Somebody's asking, and I'm not going to say their name because I don't want to violate HIPAA. They apparently have a child who has a cough variant asthma, and they're coughing all day long, using their rescue inhaler 4 times a day. This audience member says they think he needs a stronger ICS. From that description, I agree. And they're asking what they can do. And my comment is, you need to change clinicians.
I agree, Larry. I think, again, as I said, patient safety is the highest priority. And if you have a patient who's not doing well, you want to confirm the diagnosis. We don't know if the reason for the coughing all day is in fact due to asthma. It could be due to reflux.
Right. So if you look at, because I just recertified my boards, the number 1, 2, and 3 reasons for patients to come in with a cough, allergies and GERD are 2 of the top 3 reasons that they come in for. So, right. So, the biggest impediment to an accurate diagnosis is an incorrect previous diagnosis. So let's double check. And
Absolutely true, Professor. So again, postnasal drip, big reason for a cough. And so if you treat the lungs, you're not treating the problem, which is up here.
Right. And people don't realize the lungs start at the tip of the nose. So
well said, Professor.
People are asking about things like Medrol dose packs. And so I've worked both family practice and emergency medicine. We wouldn't use a Medrol dose pack for an asthma exacerbation in the ED. We hit them hard. We hit them with higher doses of prednisone. We obviously bolus them typically with methylprednisolone if they're that bad and we're trying to stave off intubation. I'm not a fan of Medrol. I don't know your comment on that, but if they need it, is there another alternative besides a burst of steroids?
No, steroids can be life-saving with a severe asthma exacerbation, Larry. So if it's methylprednisolone or prednisone, which is a prodrug, either one should work. But then, as I agree with you, they need a large dose up front. They need close monitoring. And the treatment course can range from 5 days to 12 days in that range. So it really is a very individualized decision.
So people are also asking about, do you have a special technique that you utilize in terms of counseling patients on the use of, do you advocate for the use of spacers with their inhalers? And how do you counsel patients in terms of that?
Yeah, if patients, Larry, and your experience will probably suggest this too, if they have problems with manual dexterity, a spacer may help. But most of the studies, as you know, have been done without spacers. And so I spend a great deal of time going over technique myself with the patient. And I tell them that if I rub my underarm deodorant on my nose, my armpits really stink by afternoon, to get the point home that they really need to deliver the drugs into the airways, in the thorax. And so I think, see one, do, and teach one. But spacers have helped some people, particularly in children. I think they're very
I was
useful.
just going to say, kids are the ones that I typically advocate strongly for spacers.
Yeah, I'm with you, Professor.
And I'll tell a little trick that you may have seen. My emergency department was in the middle of a really depressed area, lots of patients without any insurance. They were a lot of self-pays, and a spacer at $45 a pop was something that they couldn't afford for their kids. So I showed them how to take a small soda bottle, and with a scalpel, I would cut out the bottom of the soda bottle. Kids were very comfortable putting a soda bottle to their lips, use the puffer in the soda bottle, and then the child was able to use that as a spacer. It cost $1.39 out of the vending machine, and the child then had a spacer. So that's what I used as a kludge in the emergency department if I had to.
That's beautiful. That's beautiful.
People are asking about peak flows in the office and sending people for PFTs. If you're in a primary care office, I did PFT, or I had a individual who did them within my office who was really good at coaching patients, but it's a billable procedure, and it really makes a lot of sense to do it in the office, to send them out for every PFT. I don't know. I would encourage people to actually consider purchasing them if they don't have them. What are your thoughts?
That was the recommendation in the past, but now there have been restrictions placed on billing spirometry in the clinic. And so our practice now is actually, Larry, to send them away, particularly with the COVID precautions. Our patients are tested 2 days before they get into the lab. So we've really avoided doing in-office spirometry, and we also have avoided in-office FeNO testing, exhaled nitric oxide testing. So it's been very difficult with the pandemic.
Yeah, and certainly the case, and billing and coding changed January 1 of this year. So that was the other issue that happened. We just have trouble in this neck of the woods getting people in to see a pulmonologist in a timely manner. So, or to get that testing done in a timely manner. So, okay, Sam, I want to thank you. First, I want to congratulate you again. I understand precisely why you won that award. You are such a great clinician and a great teacher. But I want to thank you for a wonderful presentation on a very complicated subject.
Thank you so much for listening today. We hope you enjoyed this two-part podcast recorded live from the PCE Symposia series in June 2021. To claim your credit for this episode, go to pce.is/UA.